Good evening, everyone. Warm welcome to the case presentation by Yashoda Group of Hospitals. Thank you, Kola sir, for giving me this opportunity. Thank you, Team Yashoda, for giving me the opportunity. Thank you, Rakesh sir, Sheetal sir, and Pranith sir for joining in spite of your busy schedules. I know all of you are in OPDs. I am interrupting your OPDs. So we'll have for the next 1 hour, we'll have a discussion about this case of copper toxicity, which we recently dealt. Even in literature, when we went through the literature, we saw the highest amount of copper toxicity case reports, which we saw were around 20 or 25 grams. But here we are going to have a case discussion of more than 50 grams of copper, which was taken by one of our patients whom we treated successfully under guidance of all our consultants. So to take you forward about the case, we have Dr. Rakesh, our ICU consultant, who will talk about the case, and we will have a discussion as the case proceeds. Dr. Rakesh, over to you.
Good evening, all to my seniors and all my colleagues. Today, I am able to discuss, about to present the case of copper toxicity. This was an interesting case. Actually, it was a new case to us, which was recently seen in our ICU in Yashoda, Secunderabad. So, he is a 29-year-old male farmer by occupation, and he came to our hospital on 24th with the chief complaints of mainly severe abdominal pain associated with the retrosternal burning sensation. It was very severe. In here also, he was having very severe pain, and we noticed there is a blue-colored vomiting even in the outside hospital, and in our hospital also there was a bluish green-colored vomiting noticed. And there was a black color stools is a new event after coming to our hospital, and shortness of breath that got worsened from almost from the 2 days. Generalized myalgia and weakness with this is all from the 3 days. So he consumed this compound for phosphocop. So this compound contains copper and phosphorus. So in this there is a percentage actually. So 8% and 32% is labeled in the phosphocop compound. So around 8 grams, but the quantity of how much he took is unknown. So the quantity can be more. So this he took 2 days prior to coming to our hospital on 22nd, and he showed to the local hospital after taking this, where the initial resuscitation was done in the outside hospital, where the gastric lavage was given within 2 hours, and after a period of 1 day, there is worsening of RFTs. There is an increase in the AKI, and for that hemodialysis was initiated on day 2, and there was a high LDH levels in the outside hospitals. There's a very minimal evaluation was done in the outside hospital in view of worsening SOB, worsening severe abdominal pain, and he was referred to our hospital. On arrival, patient was conscious, oriented, obeying, but he is so much irritable in the ER. And saturations was around, without O2, it was around 75% only, and tachypneic, he was requiring around 10 to 15 liters of O2. There was marked icterus and cyanosis with the diffuse moderate to severe abdominal tenderness also is elicited, and AVG suggestive in the ER was metabolic acidosis with respiratory alkalosis, and the incidental finding methemoglobinemia was noticed around 8.2, and there was a saturation discrepancy in the pulse oximeter and the ABG in the ER itself.
So, Dr. Rakesh, sorry to interrupt. Okay. So this was a case of copper toxicity who presented with an acute kidney injury with methemoglobinemia. So here, Sheetal sir, so what do you think is the cause for methemoglobinemia in copper toxicity?
Copper directly, the major side effects of the copper toxicity or major effects of copper toxicity are mainly first hemolysis. Okay, the copper destabilizes the red cell membrane and it will cause lysis of the blood cells, that is hemolysis. Second one is methemoglobinemia, where the ferrous is converted into ferric compound. Fe+2 is converted into Fe+3, oxidative injury. So that itself is called methemoglobin. That is the major mechanism behind that.
So basically because of the hemolysis and conversion of ferrous to ferric form, so the methemoglobinemia happens. Pranith sir, how should we manage methemoglobinemia? Anything specific pertaining to the copper related methemoglobinemia?
See, basically, the role of a nephrologist is very minimal. We have to see the saturation gap and and also amount of the methemoglobin in the body. The basic the standard of care is exchange. We usually do with the help of transfusionists, that is blood bank. So the role of nephrologist is actually minimal in this scenario.
Sheetal sir, you want to comment anything on that?
Yeah, methemoglobinemia, there will be classical saturation gap as Pranith sir mentioned, and that is the major cause for, and methemoglobinemia is the major cause for the saturation gap. So initial stages, the first line of treatment for the methemoglobinemia is giving methylene blue, unless until it is contraindicated, or if the patient requiring high doses of methylene blue, then only we will go for exchange transfusion. Okay, so first methylene blue we have to try, and for which we have to go for G6PD levels. If they are deficient, then that is also contraindicated, then the role of exchange transfusion will come.
So basically, methemoglobinemia should be treated with methylene blue if you're based on your G6PD levels.
But in copper toxicity, if there is damage to the liver, damage to the kidney, as we expect that, so in that condition also methylene blue is contraindicated, because that mechanism of action which require for conversion of methemoglobin into the normal hemoglobin, so that will be hampered or overwhelmed in case of copper toxicity. So these two scenarios we have to understand. If we can give methylene blue, if there is no or minimal damage to the liver and kidney, we can go with methylene blue initially. And if the methylene blue is further increasing the methemoglobinemia, or if there is damage already happened, as in this case, to the liver and kidney, and G6PD deficiency is there, directly we can go for exchange transfusion in place of methylene blue.
Okay, sir. Rakesh sir, patient was having bluish colored fluids from the gastric lavage. So what could be the, of course, this is a straightforward thing wherein he consumed phosphocop. Any other differentials which we can think of?
Yeah, I think anybody coming with a vomiting that is so unusual as bluish, obviously we will focus on the history of consumption. I think the most common thing should be anything that is related to copper sulfate poisoning. But apart from this, I have seen one case sometime back where the patient had taken a boric powder. That was one time I thought it is a copper sulfate poisoning only because they have consumed some unknown powder. But when we checked in, it was found to be a boric one. So I think these are the two things that but I'm sure most of us, if somebody comes with a bluish vomiters, I'm sure you should check his history. More or less, it should be copper poisoning. That should be the first thing that should strike you.
Okay, sir. And Rakesh, if at all this patient has reached you directly, would you do a gastric lavage for this patient or not?
Actually, gastric lavage will be helpful in less than 1 hour only for anything. But this phosphocop content with of copper and all, so it is more of corrosive. So corrosive is there is a chance of mucosal damage if you do gastric lavage, and can be chance of any perforation. So it is it is not much recommended in this.
Rakesh sir, you want to take this?
The blind dictum that we always follow whenever patient has taken anything that is caustic, we look what exactly it is. If it is acidic, obviously no for a gastric lavage. So also any alkali. The only thing that I am aware of is phenol. Phenol poisoning is the only case scenario where you can confidently do a gastric lavage. Rest all cases, I think we just err on not doing a lavage. At least that's my clinical experience.
Okay, I think the answers are straightforward. Rakesh, shall we move forward?
Okay. And this is still in our hospital, and the initial labs on the day one on 24th. Actually, he reached after 2 days to our hospital after the consumption. On day one, TLC was so much high, 31,000, and INR was also raised 1.5 with a creatinine of 6.5. Already patient was dialyzed in the outside hospital. Total bilirubin 11.6. Even in outside hospital, it was around 12, and direct bilirubin was so much was higher than the indirect bilirubin, 8.4, and OTPT, and there is a transaminitis with in thousands, and the LDH is more than 4,000. It is around 6,020, and serum copper levels was also so much high. So actually, this is wrong here. It's a micro mole, actually, micromole. It is normal level is around 70 to 20. It is more, actually 50. And the G6 PD level is also is less. It is less than 5. It is 4.
So, patient was neurologically appropriate at this point of time, right?
He was irritable.
Irritable. Okay.
He was oriented, conscious, but it was a little bit irritable and semi-conscious.
So, Rakesh sir, a patient who came with a bilirubin of 8.4 with no history of any liver disease in the past, consumed copper, and his INR is 1.52. So, can we call it acute liver failure?
See, if you look at the ASLD guidelines, that is American Association of Study of Liver, their definition of ALF, any patient with rapid deterioration of liver functions, rapidity of onset, no prior disease, deranged coagulopathy, that is INR more than 1.5, and altered mentation. If these four features are present, irrespective of the bilirubin level, we clinically suspect and label them as acute liver failure. So I think your patient with a deranged INR and altered mentation, I think we should start considering ALF as one of our diagnoses, and probably because you have been insulting in the form of a copper consumption, that might be the contributing event.
So, anything specific from the treatment perspective you think of when we are considering this an acute liver failure, Rakesh sir?
See, when you are looking at ALF, especially a patient, we try to look other parameters also. Like, one is, of course, the INR, PD and INR, which is the most immediate prognostic marker with regards to liver injury. Apart from that, we also look at the enzymes. Yes, elevation of enzymes, OTPT is always considered as hepatitis, but a sudden rapid fall in the enzymes, rapid fall in the OT and PT also means that there is extensive necrosis. So, and rising lactate levels, a sharp rising lactate levels. So these are also signs of impending or an acute ALF. So I'll be definitely concerned if these are also start deranging. So elevation of lactates, rapid fall in the OTPT levels, deranged INR, in a pre-setting of altered mentation, I know that this ALF is going to be something going to be very bad.
Sheetal sir, because we were already talking about hemolysis, this patient's hemoglobin is 12.6, but LDH is 6,029. So, what are all the things we should see for whenever we are thinking of hemolysis?
See, first, the two major complications are hemolysis and methemoglobinemia. If there is hemolysis, there will be rapid fall in the hemoglobin, elevated LDH, indirect bilirubin should be high. Here, indirect bilirubin is 1.5 only. So these three things we have to consider mainly, and the saturation gap, and haptoglobin levels. All these things we have to consider to check whether the hemolysis is continuously going on or not.
Yeah, Rakesh, shall we move forward?
Okay. On day one, in your worsening RFTs, patient was started on the second dialysis in our hospital, and with broad spectrum antibiotics was initiated. In view of hepatic failure, injection NAC infusion with started, and also there is a plan for plasma exchange also for this patient if a patient is having worsening liver parameters.
Sorry to interrupt here, Dr. Rakesh. So you said broad spectrum antibiotics. So patient came with a copper toxicity. He's not on any. He's not intubated. So what do you mean by broad spectrum antibiotics? What are the ideal antibiotics which you will use for this particular patient?
Sir, already patient was admitted outside hospital for almost for 2 days, and there is a requirement of oxygen. In ER also there was a off photo, it is around 75% only, and with requirement of oxygen is there. There can be a chance of hospital acquired new infection. So that's why we started empirically before antibiotics to this patient.
No. My question was, so what? So probably a broad spectrum antibiotic in the form of a BLBLA should be sufficient, because the saturation gap is because of methemoglobinemia. So of course, in the CT, once we did a CT later. So till that time we did not do the CT, we did not know what was happening, because initially he was hypoxic and his methemoglobinemia levels were high. We were thinking it to be methemoglobinemia. So here probably we think we started on a BLBLA combination. Okay. Rakesh sir, here what is the role of N-acetylcysteine in non-paracetamol related acute liver failure? Is there any role, or how does it work out?
Well, I think we all agree that when it comes to liver failure because of paracetamol ingestion or acetaminophen, NAC plays a big role. But when it comes to these ALF that are non-acetaminophen induced, see, initial studies were like, the idea was to compare the same degree of success that we had in acetaminophen into ALF. We thought it might be useful in non-acetaminophen ALF also. The idea was that you might be able to improve a transplant-free survival, shorter hospital stay. That was the whole idea. So initial studies encouraged this. There were quite a few studies that showed that if the patient has got only grade 1 or grade 2 encephalopathy and he has ALF, early initiation of NAC might help us in get away in a transplant-free survival. But later on, I think somewhere around 2023 and 24, there were good papers coming up which actually showed that probably the effect of NAC is not that as great as we initially thought it was. So at present, the guidelines or the societies are not actively encouraging NAC for any of ALF due to non-acetaminophen injuries. So currently its role is kind of controversial. I think probably you can, if you ask my practical experience, if my patient is ALF, non-acetaminophen induced, but the grade 1 and grade 2 encephalopathy, I might still go with NAC. But if it's grade 3 and grade 4, I don't think initiating NAC may really be a game changer in these patients. That has been my practical experience.
So like whenever we have an upper GI bleed, whether it is variceal, non-variceal, we use pan infusion.
You can say that. That's like, trying to take your first luck.
So Pranith sir, what is the role of PLEX plasma exchange in acute liver failure?
Yeah, basically, we are trying to here in this case, we know the cause for the liver failure. We know that copper is a culprit. So copper is it has high volume of distribution. So for the removal of copper bound copper, that is bound to albumin and bound to that cellular plasmid, that the basic motto is removal of the molecule. So because of which we have done the PLEX. Coming to your question, that is role of PLEX in liver failure. again, it's the basic idea is to remove the bilirubin, to reduce the bilirubin, which is again a neurotoxin. So to reduce the encephalopathy related to the liver failure, and by removing the albumin, we remove the bound bilirubin to albumin, so that it helps in reducing the encephalopathy related to the liver failure.
Little more, Pranith sir. So just so what should be the ideal dosing of plasma exchange? How should you calculate the dose? And what are the various toxins wherein we should suggest a plasma exchange? A little more about plasma exchange.
Yeah, basically we calculate the dose of plasma. We calculate the calculate the plasma volume in the body. Approximately, we calculate it as 40 ml per kg. It is again classified into high volume plex and low volume plex. High volume plex is more than 60 ml per kg plasma removal. So roughly it amounts to more than 2 plasma exchange, means more than 2 times the plasma volume. That is equivalent to high volume plasma exchange. Low volume plasma exchange is approximately 40 ml per kg plasma removal. So it is equivalent to 1 to 2 volumes of plasma. Basically, it is indicated if the toxin is having high volume of distribution. If the toxin is more intracellular, means if the toxin is bound to protein, means then it will invariably have a very high volume of distribution. So to remove the bound toxins, we advocate plasmapheresis. Again, the role of plasmapheresis in poisoning is actually, to be honest, it's not that great, because the toxins are permeated so deep into the cells, it's difficult to remove. So I say the role is supplementary, not standard role.
Because, sir, about the high volume plasma exchange. So in acute liver failure, if we are planning to do a plasma exchange, do you suggest whether high volume plasma exchange or a low volume plasma exchange, sir?
Again, we stick to low volume plasma exchange usually in most of the scenarios. Again, there is no there is no clear benefit of doing high volume plasma exchange in liver failure unless there is overt encephalopathy. In that case, it might be helpful, but otherwise we'll stick to low volume plasma exchange. That is roughly removal of 40 ml per kg of plasma.
Rakesh, shall we move forward?
On day 2, in vivo persistent methemoglobinemia. So from 8.8 it went to 13. So one session of exchange transfusion was done. As G6PD levels were so much low, so methemoglobinemia was avoided and exchange transfusion was done. Later, there was a improvement in the methemoglobinemia, and oxygen saturation also got improved from 13.7 to almost 2.8 within 1 day. And there was a requirement of oxygen requirement was increased. So we did CT abdomen and CT chest also. Patient was requiring of NIV support. In CT chest, we noticed there is a pleural effusion with the collapse consolidation in the dependent part area. As we noticed, there is a high TLC count, 30,000. We started on NIV support for this patient, and chelation agent was started on day 2. D-Penicillamine, 250 mg QID as an initial starting dose. Later, we increased it to 500 mg QID, and serum copper levels was sent on day 2.
Sorry to interrupt. So, Rakesh, so how do you think whenever the patient, this could be just a transudative, right? Whenever the patient is having bilateral pleural effusions, why are you anticipating that the patient is having a secondary infection?
So TLC count, it can be infection, or it can be overload also. There was a AKI with fluid overload, that can be a component, can be seen. And with high TLC count, 30,000 around. And there are actually multiple components that lead to pleural effusion.
I think he had fever spikes, peripheral
Fever
smear
spikes also he
showed
was.
toxic granules, neutrophil
And
predominance.
in peripheral smear also we have seen toxic granules. So that we suspected a little bit of infection and started the antibiotics.
Sheetal sir, what is the role of chelation agents?
So chelation agents are actually first line of therapy. D-Penicillamine is readily available in India. So if I remember correctly, day 1, day 2, we were unable to give the D-Penicillamine because of that corrosive injury, patient was not able to swallow.
Exactly.
Already done endoscopy, then with the rails tube, with the help of rails tube, we started D-Penicillamine. Then to some extent, patients started improving. Other chelating agents, some are not available in India, like trientinin and zinc. If we give, it will work only in chronic diseases, not in acute stages. So we had given D-Penicillamine, there was some reduction in the copper levels. Initially, if I remember correctly, they are more than 50. Then they started coming down. And even after that, there is already kidney and liver damage, for which we have extended that exchange transfusion and hemodiafiltration, all those things. If available readily, D-Penicillamine we can give. If the patient is conscious and able to take orally, that will work better, because chelation agent bound copper will be dialyzed easily than the copper which is not bound to chelation agent. So that's why we prefer D-Penicillamine there.
Pranith sir, dialysis, because Sheetal sir was talking about dialysis. So chelation agent plus dialysis versus plasma exchange.
Yeah, actually, I would like to answer the first question you asked, the intensiveness, the role of antibiotics.
Sir.
I think in your case, the liver is knocked off. The liver is he's having actual liver failure, which is an important component of reticular endothelial system. So that itself is an indication for initiating broad spectrum antibiotic. That's my take. Coming to the role of dialysis versus PLEX and chelation therapy. That's the question, right?
Yes, sir.
Again, when there is organ failure, especially renal failure, if there are true indications of dialysis, then we need to initiate dialysis. We should not wait, especially when there is hyperkalemia, rise in creatinine and metabolic acidosis. All those things, when there is true indication, then we need to initiate dialysis. And basically, and there is no point of comparing it with PLEX. PLEX we are doing here as a part of treatment for the liver failure, and also to remove the bound toxin, the copper which is bound to the ceruloplasmin or albumin. So that's a main motto of doing the PLEX in this case. So yeah, both are different in my opinion, like PLEX and doing dialysis.
Yes. Rakesh, shall we move forward?
Just to chip in one point, since you
Sir.
raised, since there was a question about the D-Penicillamine as Sheetal was answering, I think what I can answer is that we have to just look at the mechanisms of the drug action. Zinc, because we use it in Wilson's disease. So zinc will competitively inhibit the copper in the GI tract. So it works at that level only. So any patient who is diagnosed as Wilson's, we want the copper not to enter the blood. So zinc works only at the GI luminal effect. Whereas the D-Penicillamine, it gets absorbed and gets into the blood system and will try to chelate the copper that is excessively present. So that is probably a wiser option for us. Again, trientine is a good drug, but again, this trientine has dual action. It works as chelator, and also it blocks at the enterocyte level. So GI effect and the chelation effect is there, but as Sheetal was mentioning, it's not available. So I think in this context of acute copper toxicity, D-Penicillamine is the wise choice if your patient can take it orally, which was rightly done there.
Yeah, and we checked the option of EDTA also, which is available here,
Mm-hmm.
but it was not given as the levels were increasing.
Yeah.
And remaining British anti-levisite and all those things we haven't tried.
Yeah, Rakesh.
So this is a trend of lab values from the admission. It is on 24th. This is on the day one. The serum copper levels came around 50. That is millimole per liter, 50 millimole per liter, and the normal level was around 11 to 12 millimoles per liter only, micromole per liter only, and counts are so much high. And on 26th, he came on 24th late night. Then we repeated on 26th. And creatinine was 5.5 after dialysis, and SGOT, SGPT reduced. On 27th, again the labs were around, total bilirubin jumped from 11.6 to 39, and here actually we planned for PLEX and did the PLEX after consulting the gastro team and nephro team, and SGPT was reduced on this day, and after first PLEX, there was not much improvement in the total bilirubin value, and it increasing further with 46. And second PLEX also we initiated on the 28th. And counts were also still high. On the third PLEX, again we did on the 29th, and the LDH levels also got reduced after these three PLEX.
So, Rakesh sir, here I wanted to ask about the bilirubin filters. Any personal experience about using filters for these patients? Here, of course, we had a PLEX for a different indication.
Mm-hmm. See, again, Dr. Manindra, I mean, there are two schools of thought. There are people who feel that bilirubin per se is a new, hepatotoxic thing. It has to be get ridden from the body. So hence, there are people who say that, in acute liver injury, when there is an excessively elevated bilirubin, these filters might be helpful in bringing this hepatotoxic metabolite out of the body. But having said that, there is an opposite school also which reserves its opinion, saying that bilirubin alone is not the culprit. If you look at ALF patients, an acute ALF patient most of the time he succumbs not because of a non-functioning liver, but it is usually the complications. Either it is the cerebral edema or the hypoglycemia or the superadded infection. So all ALF patients, invariably the cause of mortality is the cerebral edema, metabolic disturbance, or not the liver per se. So hence there are two schools of thought. Some aggressively propose it, some say that it's not of much use. So even I go with the later school. I don't feel that filters need to be actively given. That's my thought. Yes.
So, Pranith sir, you want to add anything for this?
Yeah, he's the right person.
That's why.
Yeah. Filters are available in the market. They are too costly. Like it costs more than $1 lakh. The filter itself is, and I personally never use the filter. And there is one thought. There is one possible indication is like bile acid nephropathy. Bile acid. If the bile acids are more than 40, like that, and if we are seeing the bile cast in the urine, so that is one indication where it might have some beneficial role. But as Sir said, we need to address the actual pathology. Like bilirubin filters are not going to help out in long term, but in short term, maybe yes, in reducing the bilirubin levels. Yeah.
Okay, sir. Rakesh, shall we move forward?
After second PLEX, the serum copper levels also got reduced from 50 micromole. It reduced to almost 19 with second PLEX, and with third PLEX further reduced. On day 4, to control ongoing liver damage secondary to toxicity, patient was started on plasma exchange with 8 units of FFPs, and remaining with 20% albumin was given and saline. Total 2,460 ml was given for a target of around calculated 38% of hematocrit. And on day 5, patient developed melena episodes with significant drop in hemoglobin. Blood transfusion was given, and there was a severe abdominal pain for the patient. The previous day only it was planned actually. By next day 5, the ureoscopy was done. Gastric and duodenal ulcers was noticed, and we continued the pan infusion here.
1 second. Pranith sir, so what is the ideal replacement fluid for pheresis?
There is nothing ideal. Actually, in plasma pheresis, we are taking out the proteins. So it has to be replaced with the protein. FFP has a wide variety of proteins. Apart from the globulins, it has predominantly globulins, FFP. So we need to complement it with albumin. So ideally, there is no ideal situation, ideal replacement for it. So if we anticipate any bleeding tendency, suppose we have done a biopsy yesterday, or we have done a procedure just a night before, and we are anticipating bleed. So in that scenario, we have to replace it with FFP in total. If there is not much bleeding is anticipated, then we can actually replace with FFP. So usually we complement albumin and also FFP. FFP sometimes we add, we give more just to prevent hypotension or to reduce the cost, or sometimes to to replace the albumin. In place of albumin, we use more FFP just to reduce the cost.
Is it indication specific, like TTP prefer FFPs or anything of that sort, sir?
Yeah. In TTP, if there is a bleeding tendency, ongoing bleeding tendency, then we usually give with FFP. So I have not read any specific. What I read was like, if there is a bleeding tendency, supplement with FFP. If no bleeding tendency is expected, then you can supplement with FFP and albumin both. That's it.
Yes.
Yes, sir.
Next, Rakesh.
Sir, here I got a doubt actually, whether we are transferring again with FFP. So is there any chance of again copper with the albumin? It can increase, or it can be a rebound? Anything, it can be a rebound. Again, we are giving the albumin. We are removing albumin attached with the copper, and again we are replacing the albumin again.
See, you need to understand the volume of distribution of copper. Copper usually is distributed into the red cells and binds to the ceruloplasmin, that to around 90%, around 5 to 10% albumin. So very little amount of copper will be there in the blood. So most of the copper remains in the RBCs. So if you are taking out the albumin and replacing with fresh albumin, it is very natural that the albumin might transfer from the RBCs back to the albumin and binds to the albumin. Rebound might happen, but it's again, it is bound to the albumin only.
It will maintain the normal copper levels in the body.
But what we measure is the free copper levels. What we measure is the free copper levels. So that may not measure the bound albumin.
Sheetal, sir.
Yeah, the free copper levels are only toxic material. So in PLEX, there will be definitely rebound copper levels if you do PLEX only.
Okay.
Shall we move for Rakesh?
So total 3 sessions of plasma exchange were done. in view of acute liver failure, and dialysis was continued in view of AKI. So on day 8, he was almost improved, but he was requiring of NIV support with HFNC or NIV support. Respiratory distress worsened on day 8 actually. Persistent tachypnea, increased oxygen requirement. There is a worsening PF ratios also, and leukocyte like cytosis was there. Fever spikes continues. So on day 8, we checked the lung ultrasound, fluid overload was there with the lower zone steadings and all. And initially tried with an HFNC, NIV, and later patient got worsened, requiring of oxygen, and we intubated the patient. Uh, there was mild ARDS noticed in the ABG, and we repeated the CT scan second time. This time the ARDS got worsened, and the consolidation and the area of Jesus was increased than the previous scan.
Next slide.
And this is a further lab values post after 30th of and there is total bilirubin was 28. From there it decreased to 22, and from there it decreased to almost 8.3. Transaminase is also got decreased, and serum copper levels after the third PLEX it came down to 16 from the 50 micromoles per liter.
So, Sheetal sir, so patient got, when was that patient got discharged, sir?
Yeah, actually, the difficult part was counseling. So they were completely illiterate. So in last 5 years in Yashoda, this is the first case of biopesticide with copper. Remaining all biopesticides were with majorly methemoglobinemia, and we have done 5 exchange transfusion, and the patient used to recover. Only one patient succumbed because of high methemoglobinemia, around 80%. So this is the first case which is having copper in that biopesticide. And the interesting thing is the copper containing biopesticides are available only in Southeast Asia and mainly in South India to encourage that organic farming. And most of the people doesn't know that it will be harmful for the human beings also if taken in high doses as a poison. So the patient got discharged after 7 days of staying in general ward. And if I remember correctly, a patient got admitted 3 days before again, and we have done 2 dialysis. When sir, correct now?
Yes.
We have done
Oh,
two dialysis.
we have done one.
One dialysis, and patient creatinine came down to 5, and we discharged him, expecting that his kidneys will improve.
He is non-oliguric. Non-oliguric. Actually, that session of dialysis also should not have been done. That time he was pouring good amount of urine because he came in the night and we was informed over phone, and like proper details were not known to us. So it was he was initiated dialysis in emergency overnight. But actually he was pouring good amount of urine and no, totally like there is no volume overload. There is not much hyperkalemia.
Actually, he came for acute gastritis. Came with the complaints of acute gastritis. We started pan infusion also, but they were saying there is no urine and severe acidosis. Patient was in irritable state. That's why immediately dialysis was started.
Yeah, it looked like he was in a recovering phase that at that moment. After that, he didn't come to my OP. Yeah, he was discharged, I think.
Kola sir, Venkatraman sir, you want to add anything, sir?
No, I think 1 second.
We had a discussion about this patient with sir.
Yes. No, I was actually listening to all of you. To me, heavy metal poisonings were a chronic issues. It was never so acute. I hope all of you agree. I don't know whether as a gastroenterologist, Rakesh sir seeing more acute copper poisonings, but in my 20 years of critical care practice as a core critical care clinician, copper sulfate as a toxin in acute leading to acute liver failure or acute renal failure, were very few. It is one of those few cases which we came up. Chronic were known, as we were all talking about a spectrum of things, including, I think, as a part of CLD workups or acute on chronic CLD workup. And this case, which brought us that arena of spectrum, from we were talking about a local effect of GI mucosal injury to a liver toxicity to a renal toxicity to a cellular hemolysis, methemoglobinemia, needing a team efforts from gastro, nephro, a internal physician who has been the primary clinician and intensive care team. I think it was a learning experience. That's the reason we brought this. And as rightly pointed out by Dr. Sheetal Kumar, ki the paraquat and these kind of heavy metal induced herbicidals or these agricultural toxins are been a concerns to many of us. But I think this discussion brought us this spectrum. We know many times we were talking about toxin removal by different filters, as you all discussed about either heme adsorption or a removal of bilirubin or a PLEX. These all go through a different controversial debates, and I think this is an eye opener for me too. So that's the reason we brought this case. I just wanted to ask how frequently we see this kind of cases in your practice. Rakesh sir from Gastro, how frequently you see these cases?
No, Dr. Gora, as you have rightly pointed out, I think when it comes to these metals, whether it's copper dysregulated metabolism leading to Wilson's is what we see. Iron dysregulated metabolism leading to hematochromatosis is what we see. So it's always been a slow chronic CLDs, sometimes acute hepatitis. That's the max we see. At least I haven't seen a patient coming with such a high acute copper toxicity. Of course, the presentation is ALF, but the etiology being copper toxicity acute is something that I haven't seen. So I think it was a good job on all end. I think everybody did a good job in rescuing the patient. I think
Probably Manindra, this is a task to the critical care team. Sheetal
Yeah.
sir, being a primary clinician, all of you together put this
Sure.
case report to either a IJCCR
Yeah.
or a BMJ, and this should be I think a spectrum
So
of
one,
yeah.
yeah.
Pranith Rama. How
So
frequent?
one confession I would like to make in this platform. Actually, we did hemodiafiltration for this patient. Almost all the initial sessions were hemodiafiltration. Like in we routine dialysis was not done actually. We did hemodiafiltration, anticipating middle molecule removal with high flow hemodiafiltration. Almost all the sessions in the initial phase we did that. So actually, most of the studies in poisoning were on the hemodialysis. Here, why we did was like because the copper is the culprit, and it causes it initiates the inflammation. It causes the lipid damage. So it basically initiates the inflammation. So to remove that middle molecular cytokines and all, and also copper removal, and also it causes hemolysis. So all those things were kept in mind. So and it was advised. No, it was advised in that aspect actually. So for me, it is also learning. Uh, it just worked in this patient. Yeah.
Sheetal sir, how frequently you have seen this kind of case?
No, sir. This is my first case having copper in such a high dose and acute copper poisoning. We used to see biopesticides with methemoglobin. That is more common. And surprisingly, in this patient, first thing, as far as I remember, first we have done plasma exchange, and that removed methemoglobinemia completely. After that, as Pranith sir said, we have done hemodiafiltrations only. So we were thinking in terms of methemoglobinemia only. Suddenly, after seeing that bottle which contains high amount of the copper and phosphorus, then we sent copper levels. Dr. Harish sir was there discussing regarding that amount of the copper in this, and this is the first time we are seeing a copper as a component of that biopesticide. Then we realized it can be acute copper damage. Then better we sent. and we got that report after 2 days, surprisingly. And that was 50, and D-Penicillamine, we make it available, we made it available, and we have done endoscopy, we put trials tube. Then only we were able to put the D-Penicillamine. Till that time, we were relying on PLEX only.
Interesting, sir. Actually, by coincidence, I was just walking through the cases, and suddenly I came across this. And somebody told that this is a copper intoxication leading to organ failure 1, 2, 3. I just hold it back there. I said, it's not common. I have not seen a case like this. I reviewed the case details and I went back to all those which we all been discussing. And that's the reason we felt this is a case to be reported. This is a case to be discussed. This is a case to be brought into this kind of master classes. And I think we all were able to put that across, and a interesting discussion, wisdom sharing, and this is how a learning process happens. I think that's my conclusion talk. Over to you, Manindra.
Sir, Sheetal sir, any concluding comments?
Nothing, sir. Such type of rare cases we have to consider as presenting as paper, and next time if this case comes, it will be a cakewalk for us.
True.
We are already preparing the case report, sir.
Done.
Pranith sir, any closing remarks?
Yeah, nothing much, sir. Thank you. Thank you for having me. It's a learning point.
No.
I learned a lot through this case by reviewing the literature. And
Thank you for
yeah.
accepting and being here in spite of your other commitments. Thank you, sir.
Yeah, fine. Thank you. Thank you.
Rakesh sir, any closing remarks?
I think all I can say is that, there was, it was a very good, I had many learning points, and at the end it was job well done. Maybe team effort all the way.
Thank you, Rakesh, for taking all the efforts in presenting the case. Thank you, Kola sir, for the opportunity. Shall we log out, sir?
Yes. Thank you, Manindra, for a wonderful moderation. I think we conclude the session. Thank you all.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.